Hello, everyone. We're going to talk a little bit about immune system modulation. So the prototypes that are covered in this lecture are these three: alpha-2b, cyclosporin, and rituximab. Sorry, alpha-2b interferon. So if you go back and look at the vaccine lecture, you'll see that I talked about two kinds of immunity. I talked about humoral immunity and I talked about cell-mediated immunity. And so now we're going to focus on cell-mediated immunity and the drugs that are responsible for their action based on cell-mediated immunity. So cell-mediated is based on T cells, and we have two types of T cells. We have helper T cells. They activate all other immune cells, including B cells, i.e. antibodies are humoral immunity. And then we have cytotoxic T cells, which are killers of bacteria, viruses, parasites, and cancer cells. These cytotoxic T cells produce cytokines. Cytokines can kill things. They can also trigger inflammation, but they can also sort of enhance the killing power of macrophages to go out and sort of eat stuff. So this immune system, this cell-mediated immunity based on the T cells, is being manipulated to create drugs that both stimulate and suppress the immune system. So as we're going through this, you may be doing some why, or how questions. I just want to let you know this is highly complex. When you start talking about the immune system, this is really elegant, fancy stuff. And you want to talk about bodies that are phenomenal. This is another system where you could just step back and be like, whoa, like how did this all come to be? Okay, so let's talk about immunostimulants first. And we have three kinds that we're going to talk about. Immunostimulants do kind of what that word sounds like. They actually stimulate or increase the ability of the immune system to fight disease. So we have biologic response modifiers. We're going to talk about those more later. We have interferons and we have interleukins. And we're going to talk about interferons as well. So those are part of our prototypes. So biologic response modifiers boost specific functions of the immune system. And one that you've already learned is filgrastim, which is the drug Neupogen. We know that's its trade name. That's how it's sort of spoken of out in the clinical setting. But we know that it stimulates the bone marrow to produce white blood cells. That's really helpful for patients who've had chemotherapy, whose bone marrow has been kind of knocked down a peg or two by that chemotherapy and who are at risk for infection. So by giving filgrastim, we actually stimulate their white count. We stimulate their bone marrow to make white blood cells, which increases their ability to fight infection. And patients now have smaller windows of being neutropenic. And I'm sure you remember that. Remember, NEU, neutro, has to do with neutrophils, which fight infections. So that's kind of a cool thing. Interferons have been around quite a long time. I was learning about them when I was in nursing school. They're secreted by lymphocytes that have been infected by a virus, and they warn the surrounding cells that infection has occurred. And they kind of flag things like, hello, there's a problem over here. And that allows the body's immune system to go in and sort of, target those cells. So these drugs have antiviral, anti-cancer, anti-inflammatory properties. And then interleukins. And interleukins were just being studied when I was a new grad, and they are secreted by lymphocytes and macrophages. Remember, macrophages are those cells that eat bacteria, viruses, things in response to an antigen, has a widespread effect on the immune system. And what I remember about them as a new nurse is that I never, ever wanted to give these drugs. They were very scary, and I was worried about what was going to happen to my patient. So our prototype for immunostimulants is interferon alpha 2b. And again, this is a biologic response modifier. It alerts the patient's immune system. So we talked about that, like, kind of imagine somebody whistling, like hailing a cab, like, hey, over here, except that, when the cab comes, then the cell gets killed. And so it's used to treat like hairy cell leukemia, which is not super common, malignant melanoma, which is very common, non-Hodgkin's lymphoma. This is HPV infection, right? Human papillomavirus and chronic hepatitis. It can be administered IM or IV. I don't care if you know that as much, but it really must be given by someone experienced with the drug. And I would say that about all of the drugs in this particular lecture is these are most often given by infusion nurses or hematology oncology nurses who really know how to give these drugs a watch. They know all the things to watch for. So adverse effects. Check this out. 50% of patients experience fever, chills, dizziness, fatigue. So that is a normal side effect. Headache, nausea, vomiting, diarrhea, anorexia. And it does have a black box warning, which is that it may cause or aggravate fatal, apologize for that, or life-threatening neuropsychiatric, autoimmune, ischemic, or infectious disorders. So bottom line is, even though this drug works great, it also can make you really, really sick. Nursing care for this is to monitor labs, mostly hepatic enzymes, and triglyceride levels. Okay, immunosuppression. I have a little picture of a dial here, and you could think of it as, a volume dial or whatever you want to think of. But I really like to think of immunosuppression as turning down the volume on your immune response, making it not quite so sensitive to the things that it sees out there so that it doesn't respond so quickly. And actually, this has been used for a very long time for a lot of novel treatments. One of the things that we've used for is transplantation. Immunosuppressants are given to dampen the immune response and retain the organ. Think about it. If I get someone else's heart, let's say even my husband's heart, just because we've been married for 40 years doesn't mean anything. Let's say he, dies in a tragic, I don't know, yard accident. Just kidding. And I end up needing a heart transplant and I get his heart. Well, my body's going to recognize his tissue as foreign. And as a result of that, my body's going to send in all kinds of responses to try and attack that foreign object and get it out and kill it. And so we use immunosuppression to turn the immune system down, not so much that our patient dies from infection, which is always the risk, but enough that they can keep the organ. So it's this careful balance between rejection and life-threatening infection, right? Think of that almost like a scale, like we're trying to get it balanced so that basically we can keep that organ intact. And it's used for all kinds of transplants. It's used for heart, lung, kidney, bone marrow transplant. So, but just so you know, long-term survivors of transplants are at high risk for developing cancer, especially lymphoma, skin cancer. And for this particular and Kaposi sarcoma. And Kaposi sarcoma is not something that you guys see very much, but it's a cancer that's related to HIV. And then the other thing that we do immunosuppression on is acute inflammatory disease. And a lot of times we think of autoimmune diseases where our own body is attacking our own tissues. And this is felt to be the case in a number of things that we see, especially chronic illnesses. So rheumatoid arthritis, lupus, psoriasis, ulcerative colitis, Crohn's disease. Myasthenia gravis is less common, but still thought to be autoimmune nonetheless. And that's basically where it attacks muscles and nerves, and you feel almost like you're moving underwater, very slow. So pathophysiology of these kinds of drugs is that they non-selectively affect T cell function. We have some newer drugs that are maybe a little bit more targeted to specific T cells. These drugs are highly toxic to bone marrow, and as a result can cause serious adverse effects. And we're going to talk about that. So during treatment, patients are highly susceptible to all pathogens, and infections are common. In fact, people who are known to be positive for certain viruses like CMV or other viruses may actually go on prophylactic medication to protect them during this time. Some of the immunosuppressive drugs that you've learned about and that we're going to continue to talk about are corticosteroids. Remember our friend prednisone, wonder drug, terrible drug, antimetabolites like methotrexate, calcineurin inhibitors, we're going to talk about one today, and antibodies. Chemo is immunosuppressive as well, but I just want to say that it's immunosuppressive as a result, not of its effect on this system, although that's not even 100% true. Its effect is due to the fact that it just wipes out the bone marrow, which makes lymphocytes and white blood cells and everything else. So yeah, that's why it causes problems. All right, on. So our prototype for immunosuppressant is cyclosporin. This drug has been around for like probably a bajillion years now, probably 100 years. It is a very potent immune suppressant. It actually comes from dirt fungus, very interesting. It is a calcineurin inhibitor. I am not going to tell you any more about that or calcineurin other than to say that it inhibits T helper cells, which suppress immune response to foreign tissue. It has a very narrow therapeutic index, meaning too high and it's toxic, too low, and it's not doing the job that it needs to do. So cyclosporin levels are taken like many other drugs with a narrow therapeutic index. This is a drug that needs to be monitored by level. It can be used also for like autoimmune disease like psoriasis, ulcerative colitis, Crohn's disease. I actually had my in-laws actually had a dog that was taking cyclosporin because it had such terrible skin issues, and it really helped this dog a lot. Adverse effects are immunosuppression. I think this is fascinating though. 75% of people taking this drug experience reduction in kidney function with decreased urine output. Now that sounds like an adverse effect that you really should know about this drug. Same with the second one, more than 50% have hypertension and tremor. And I think it's very interesting that they have hypertension and there's a reduction in kidney function. So what the heck does this drug do to these kidneys? Gingival hyperplasia, it's sort of like Dilantin, which you might remember from Pharm, and it causes, Dilantin is an anti-seizure drug, and it causes your gums to overgrow. It can be very unsightly, even though you are trying to have good mouth hygiene, it looks like you don't. And then elevated hepatic enzymes. So a second slide about this same drug. It has a black box warning. It should only be administered by healthcare providers experienced in immunosuppressive therapy. And I think what that really means is that it should be monitored, because a lot of these patients take this orally at home. But you need to be watching for all of the symptoms and side effects that can occur. So serious infection, possible malignancy, anything that suppresses your immune system makes you at risk for getting cancer, period, the end. So you need to remember that about all drugs, like the ones on this previous slide that suppress the immune system. And then nephrotoxicity at high doses. Well, that makes sense given the fact that, 75% of patients have reduced kidney function. And then you shouldn't get it if you've had a prior hypersensitivity to the drug. And check this out. You know how we talk about food-drug interactions? Well, yowza, here's probably the biggest one I can think of. Grapefruit juice can increase drug levels by 50 to 200%. So guess what some of your patient teaching is? These patients are not to drink grapefruit juice while they are on this drug. Drug-drug interactions, there are many, many. So it's one of those drugs that if you're going to give it, you need to be really careful. And I think what's so sad is that as I look at this, yes, anti-seizure meds, but all these drugs down here, azoles, ACE inhibitors, NSAIDs, macrolide antibiotics, they can increase drug levels. Well, frankly, most of the people who are getting these drugs tend to have issues, right? They have immunosuppressive issues, so they may be on an antifungal drug because they got a fungus infection. They may be on an ACE inhibitor because they are having kidney problems as a result of this drug. And NSAIDs, right? This is, again, something like Tylenol. This is something that we would use frequently in this population, and antibiotics. So I just found that a really interesting drug-drug interaction, and that these things do increase drug levels. And maybe the way it's dealt with is that patients still take these drugs and still take their cyclosporin, but their cyclosporin doses have to be adjusted down so that, yeah, they're not toxic. And then nursing care, again, patients are at high risk for infection. You need to monitor labs for infection, for organ function, drug levels, educate patient family on side effects and adverse experiences. Okay, monoclonal antibodies. You have probably heard about this. They are being advertised constantly, whether it's on the web or social media. But they are sort of the newest drugs we have for treatment of cancer and other immune-related diseases. However, I think we thought early on that these would just be a cure-all, and even though they're highly targeted to specific cancer cells or other things, they aren't a cure-all, and there are lots of side effects, and they don't always work, and we don't necessarily understand why. And it's still a ton of research is being done on this to try to figure out why some of these work really great and why some of them don't. But monoclonal antibodies are made by injecting human T cells into an animal, often a mouse, but we'll talk about that later, which recognizes the cells as foreign and creates the antibodies. So it's kind of interesting. It's like we get something else to make antibodies to something that's harming us. And then these are purified, they're replicated, and they're purified and injected back into humans so they will attack these T cells, kind of like autoimmune disease, or they will attack a tumor, which I have a really good video for you in this one. Okay, you're going to hear all kinds of crazy names for these drugs. Just looking in your book, if you go into drugs for immune system modulation and you look at all of the different names of, actually it's in chapter 38, and all the different names for monoclonal antibodies, holy moly, there are a million names. Let me just read you some of them. Here we go. Brigatinib, brentuximab, carfliximab, ceritinib, cetuximab, crizotinib, gefitinib, imatinib, Here's one up here that you guys learned, I think. Yeah, bevacizumab, Avastin. How are these named? Well, they're named by looking at MAB means monoclonal antibody, MOMAB means mouse, ZyMab means between a mouse and something else, oftentimes a human. Zumab means humanized. I don't care if you know these. I'm just explaining to you where these crazy names come from. Mumab is human monoclonal antibody. So let's just look at our prototype for this is rituximab. It's down at the bottom. And I'm not sure what RI is, but TU is tumor directed, XI means chimeric, and MAB means monoclonal antibody. So it is a cancer-directed chimeric monoclonal antibody. And I'll look up the RI and we'll talk about it in class, but I think that is so fast. So here's our prototype, which is rituximab. Rituxan has been around for a long time. It was one of the first monoclonal antibodies that we gave. It is used to treat lymphoma, rheumatoid arthritis, and it's off-label for many other autoimmune diseases. We have some friends whose son has taken it for Crohn's disease, actually for ulcerative colitis. It attaches to CD20 positive tumor cells or antibodies and causes cell death. So for autoimmune diseases, it's attaching to antibodies that are attacking, our own tissues. 80 to 90% of patients experience an allergic or anaphylactic reaction with infusion. Holy cow, that is huge. But these can be managed with pre-medication and slow titration of infusion rate, usually. And nurses, who are the ones giving this drug, are key. They are critical to medication safety. So nurses who give these drugs, they got to know what they need to do beforehand. Probably each patient has his or her own preferred pre-treatment, pre-medication. And then you have to have a nurse that has to be ready to pull that crash cart and call a code if needed, if they anaphylax and lose their airway. I know that in the treatment center where associated with the hospital that I was at in San Diego, we definitely had one girl who every time she got this drug, she basically had almost an anaphylactic reaction. And it required her, I know several times she went to the intensive care unit, but it required us to have epi and other things around to manage her reactions. So it's but it's used a lot. So I think that we've gotten much better at managing those reactions. Pre-medicating people, think about what would we pre-medicate with to prevent an allergic reaction. Those are some meds that you should know of and think about. And then our job for nursing care is monitoring for reactions, being able to treat those, and then treating and managing multiple bacterial, fungal, viral infections, lymphopenia, which is low lymphocytes, leukopenia, which is low white blood cells, and neutropenia, thrombocytopenia, and anemia. So you're going to have a low immune system. You're going to have, people who may need blood transfusions, may need platelets, may need other things as a result of this. Okay, guys, that's it for this particular lecture. Sorry, it's a little bit longer, but it is very complicated. So